So the purpose of today's call is to provide an introductory overview of the new MCV performance measures that all MCV grantees are held accountable to, and by extension, all Michigan Home Visiting Initiative grantees are held accountable to. We'll listen to that in just a minute, but the first thing I'd like to do is remind everyone to please mute your phone lines if you haven't already. I'm not hearing any background noise at the moment, which is awesome, but just remember to mute those lines that we don't get that, that stick in the background. So let's just talk quickly about who's here in the room. Again, this is Julia Heaney with MPHI, and I think as most of you know, my role is the PI for the home visiting MCV grant here in Michigan. So my team here at MPHI coordinates benchmark data collection and reporting and the quality improvement work that happens under the Michigan Home Visiting Initiative. And we are honored to be involved in all of the great work that you're all doing with families in the way that we are. I'm joined today by Angie Precht. Do you want to give an introduction to yourself?
Sure. Good afternoon, everyone. This is Angie Precht. If you don't know already, I provide assistance on both benchmark data collection and continuous quality improvement, specifically with our Nurse Family Partnership sites, and we're really happy to talk with you today.
This is Robin Vandermoor, and again, I think most of you know my role and what I do, but I oversee the implementation of the quality improvement plan for the Michigan Home Visiting Initiative.
Thank you. And we also have actually two other members of our team in the room here that are not on the phone line. I'm sorry, not on the slide. They are on the phone line. They are not on the slide, but are really critical members of our team and have been doing a ton of work in the background getting us ready to report under these new performance measures. Monal Shroff, whose name, again, is probably familiar to many of you, and Carrie Soroka are here as well to kind of hear what we're talking about here, any questions that you have toward the end, and to make sure that I don't mess up in talking about these measures as we move along here today. So get into what we're going to be talking about. Some months ago, but actually last fall, we started talking about the new performance measures that would be released under MCV that were kind of in progress through HRSA and the partners that they have at the federal level, and thinking about they need to make sure that MCV continues to be successful, continues to be funded, continues to receive strong bipartisan support. They've been working on this. They worked on this for about a year and a half of thinking about what do we really need to know from all of the MCV grantees across the country to make sure that this really critical stream of funding for home visiting continues to receive the level of support that it has. The fall, they released a set of draft performance measures, which went through a vetting process. So there was a public comment period. They convened some groups to provide some feedback on them. They took all of that feedback in the winter, made some revisions, and in the early spring released a final set of performance measures. As is always the case when a process like this unfolds, the performance measures have gotten a lot of sort of additional feedback. So there's been a lengthy process of grantees like Austin, Michigan, looking at these measures, thinking about what do you really mean, how should we be gathering this data, when do we need to report it, and kind of going back and forth and creating a better understanding of what each of these measures are. Our responsibility as a state to HRSA has been to provide a data collection and reporting plan which specifies for Michigan how we're going to report data under each of the performance measures. So over the past, since May or so, that's been one of the pieces of work that MPHI has been doing to prepare our state to begin gathering data, and then in fiscal year 17, at the end of fiscal year 17, being able to report under these new performance measures. So we're going to go into some detail about what those performance measures are to give you kind of a general sense of what we are going to be held accountable to in the future under MCV funding and Michigan Home Visiting Initiative funding. Then we're going to talk a little bit about next steps. What I will be diving into in the hour we have together today is how each of these measures will be reported under each of the different models that we have receive funding through the Michigan Home Visiting Initiative. We don't have quite enough time, and the details of that, honestly, are still being worked out for each of the different data systems of exactly how data will be collected and reported. To prepare us for that discussion, which will be coming in, we thought it would be important to kind of offer an overview of where we're going, why these changes are occurring with the data systems, and what that is going to lead to at the end of next year as far as our reporting goes. And then hopefully we'll have a little bit of time for some questions about the measures themselves. And I apologize for my scratchy voice and my coughing. Okay. As a reminder, when the MCV funding came through, it was part of the Affordable Care Act, and in the legislation, it specified that home visiting achieves a set of 6 types of outcomes, and that when funding was released under this program, these would report on their progress in each of these outcome areas. Literature on home visiting programs from evidence-based programs and the studies that demonstrated their effectiveness in these areas. So improving maternal newborn health, home visiting reduces child injuries, abuse, and neglect, improves school readiness, and it reduces domestic violence, it improves self-sufficiency, it improves service coordination. And according to the legislation and in the various iterations of funding mechanisms that have supported MCV, this kind of idea has been reiterated that funding for home visiting is dependent on our ability to demonstrate that these outcomes are being achieved through the implementation of programs. So that's what we are trying to set up a system to allow us to do. The impetus for changing the benchmark measures that we've been reporting on is really twofold. One, that they wanted to reduce the overall number of measures that we were reporting on. So at the end of this year, and for the 4 years, we've been reporting on 37 measures. I apologize, excuse me. That number, it will be reduced to 19. It has been reduced to 19 in this set. The impetus was to create consistency in exactly what is being measured by all of the MCV grantees across the country. So what that has meant is that the measures as they've been defined are much more structured. So all of the states are doing something much similar to one another now than they ever have in the past, and everyone is measuring much closer to the same thing and along the same time frames. Thank you. Frames for measurement, as you'll see, are much more specific and much more nuanced to each measure than in the past. There's a huge focus on eliminating missing data as much as possible. Other change that you'll see is screening male primary caregivers for depression and domestic violence has been included in this set. We're also going to be collecting information on the performance measures about all target children. And the key change that I would suggest that we should keep in mind is that these measures are continuing to evolve. We're learning more about them on a weekly basis. We're learning more about how each of the models is thinking about them on a weekly basis. We're seeing changes to forms, greater definition, more specificity from HRSA. So the information has been coming fast and furious and continues to come. And we are doing our best to understand what the expectation is and to translate that as cleanly possibly can in measures. Am I muted? So I had someone else join us, so just a reminder to mute your phones when you get on the line. All right, I think we're ready to jump in and look at the measures themselves. Measures that we'll be reporting on will come from state data, and these are fairly similar to what we've been reporting on in the past and through our vital records and DHS data polls. So the first measure is focused on preterm births, and what what I would like to see is that home visiting programs are reducing preterm births. So you see the definition here, the percent of infants, mothers enrolled in home visiting prenatally before 37 weeks who are in preterm following program enrollment. So they're telling us, focus on those moms that enrolled before 37 weeks of gestation, and for each of those moms, know if their baby was born preterm or if their baby was not born preterm. And this is data that we can get out of our Vital Records data system, and in the same way that we have in the past been gathering information about adequacy of prenatal care. Next measure also would like to see is a reduction in children that are being served who have investigated cases of child maltreatment. So in case, what we're looking at is the percent of children enrolled in home visiting with at least one investigated case of maltreatment enrollment within the reporting period. This measure will be looking at all of the children that you serve and looking in the DHS system to see if there is an investigated case of child maltreatment since the point of enrollment. Of the measures, the other 17 will come from the data that you are collecting and submitting. That is about primary caregiver education. So what HRSA is looking for here is that if a caregiver hasn't completed high school yet, that they're either staying in school till they complete or are completing their education. The measure itself is a little bit confusing, but the way that it reads, the percent of primary caregivers enrolled in home visiting without a high school degree or who subsequently enroll in, then continuous enrollment in, or complete high school or equivalent during their participation in home visiting. What we're looking here basically to see is that if a caregiver hasn't completed high school, that they are working towards the completion of their diploma or GED. If they're not enrolled, that they're getting enrolled is the focus of this performance measure. The next one, continuity of insurance coverage. Here, what HRSA wants us to demonstrate is that caregivers have continuous health insurance, specifically continuous health insurance for 6 months. So they want to know the percent of primary caregivers enrolled in home visiting who've had continuous insurance coverage for at least 6 consecutive months. Here is about postpartum care. And what HRSA would like to see here is an increase in postpartum visit completion by 8 weeks postpartum. What we'll be asked to report on is the percent of moms in home visiting who enroll prenatally or who enroll within 30 days of delivery, who received a postpartum visit with a healthcare provider within 8 weeks of delivery. So again, they're telling us only look at those moms who enroll prenatally or within 30 days of delivery who have that completed within 8 weeks. The next one is well child visits. And we're looking for an increase of children getting their well child visits on time. So what the measure is the percent of children enrolled in home visiting who received the last recommended visit based on the AAP Academy of Pediatrics schedule. So this one is an example of where I said the timing is a little bit more tricky of some of these measures. So having the last recommended well child visit is really in relationship to home visit that was conducted for that child. So imagining that what we'll be doing is kind of on an ongoing basis collecting information about the completion of well child visits and saying if the time you saw this family was right after their 4-week visit, do we have documentation that they completed that 4-week visit? And take 1 second to take a drink here. The next measure is focused on child injury, and so we're looking for a decrease in children's injury-related emergency department visits. So the rate of injury-related visits since among children enrolled in home visiting. So what they're looking for here is a count of every time a kid has been to the emergency department for a non-fatal injury. There is about breastfeeding. If you remember, right now we've been focused on breastfeeding initiation, and that will change with this of measures, where HRSA is really looking for how many to enroll during prenatal period are still breastfeeding at 6 months. So the percent of infants among mothers enrolled in home visiting prenatally who were fed any amount at 6 months of age. Is focused on safe sleep, and so here what we're looking for is infants sleeping on their back in a safe sleep environment. So the specific measure, the percent of infants enrolled in home visiting that are always placed to sleep on their backs without bed sharing or soft bedding. What's important, what we've learned is important to HRSA about this measure is that we are looking both at are being placed to sleep on their back and are they sleep in a safe environment. The measure HRSA came up with to get at language and literacy support is that they'd like us to tell them the percent of children who are read to or hearing stories or songs every day. Specifically, they want to know the percent of children that you're serving, family member who might be the caregiver, it might be somebody else, who reported that during a typical week, he or he read, told stories, and or sang songs with their child daily, meaning every day of the week. The next is about parent-child interaction, and this is focused on the completion of a screening tool. So they want to see that all families have had a screening tool that's focused on caregiver-child observations completed within the course of the reporting period. That is the percent of primary caregivers enrolled in home visiting who receive an observation of caregiver-child interaction by the home visitor using a validated tool. The measure is focused on behavioral concerns. What we're looking for is the percent of home visits or an increase in the percent of home visits where caregivers are being asked if they have any developmental concerns about their child. One where the timing is different, is tricky, because what they really want to know is the percent not of parents or of children, but the percent of home visits where the primary caregiver was asked if they have any concerns regarding their child's development, behavior, or learning. So whereas we've never had any measures in the past that have had home visits as the denominator, home visits as the thing that we're counting, this is the time we've seen. And so that is one of the larger changes around timing of data collection is getting this information under home visit and being able to report it at that level. Next measure is about developmental screening. So this is a very familiar one. So this is focused on the percent of children who are receiving a developmental screening. The measure specifically is the percent of children enrolled in home visiting with a timely screen for developmental delays using a validated parent-completed tool. So this is very, very similar to what you've been doing so far. The next measure is taking that screening and talking about referrals. This is something that we haven't reported on in the past. Looking here at the children who have a positive developmental screen who receive services. So this is just receiving a referral, but receiving services of some kind. And we'll talk about that in just a second. But parents of children enrolled at home visiting with positive screens for developmental delays measured using a validated tool who received services in a timely manner. What's interesting about this is that if you look at the numerator in the second column in the top, what it means to receive services is fairly nuanced. So they're counting as having received services, received individualized developmental support from a home visitor, having referred to early intervention services, and receiving an evaluation within 45 days, or being referred to other community services and having received services in 30 days. So there's a variety of things that can count under this measure as having received services, but it's taking the next step of not only are we documenting that there was screening done and the screening was positive, but that a referral was made and that the kiddo is receiving services. The next measure is focused on depression screening. So what HRSA is looking for here is that depression screenings are being completed for both male and female primary caregivers within 3 months of enrollment, or if mom enrolls prenatally within 3 months of giving birth. Again, the timing of this is very nuanced, a little bit different than what we've had in the past, both in the sense of we're talking about screening both men and women, and we're looking at that time frame of 3 months of enrollment, or for prenatal clients, 3 months of birth. So the specific measure, the percent of primary caregivers enrolled visiting who are screened for depression using a validated tool within 3 months of enrollment for those not enrolled prenatally, or within 3 months of delivery for those enrolled prenatally. Similar to the developmental screening question, here what we're looking for is the percent of caregivers who screen positive for depression, again, who are receiving services. So going beyond receiving a referral to receiving services. So the measure itself, the percent of primary caregivers referred to services for a positive screen for depression who receive one or more service contacts is what will be counted as having received services, having received one or more service contacts. This measure, again, a familiar one, intimate partner violence screening. And here we're looking for the percent of caregivers who are screened for interpersonal violence within 6 months. The main difference here is that we're talking about both men being screened and women being screened, as opposed to only women, as we've counted in the past. Here we're looking at the percent of primary caregivers enrolled in home visiting who are screened for interpersonal violence within 6 months of enrollment using a validated tool. This measure is not one we've reported on before, but sort of a more familiar concept. So what we're looking for here is the percent of primary caregivers enrolled in home visiting with a positive screen for interpersonal violence using a validated tool who receive referral information to IPV resources. And so here the difference in what we've reported on in the past is that we're talking about both men and women receiving referrals following positive screen. This was a little bit new to us as well, tobacco cessation referrals. I think this is something that many of you are already doing, but something that we've never really captured data about in this way before. So what we're looking for here is the referrals for tobacco that are happening within 3 months of enrollment. So the specific measures, percent of primary caregivers enrolled in home visiting who reported using tobacco or cigarettes at enrollment, and referred to tobacco cessation counseling or services within 3 months of enrollment. So what this measure is asking to happen is that within the first 3 months of enrollment, caregivers are being screened for tobacco, that they are receiving a referral if that screening is positive. As a very quick run through of the new 19 measures that we will be reporting on and will be held accountable to beginning being reported after the end of next fiscal year that we will be beginning to collect data on in fiscal year 17 in October. So that's what we need to be able to do is report on this at the end of next fiscal year. We have quite a few next steps, and we want to give you a quick picture of what that's going to look like. Before that, we're going to do a quick survey, which will be great because I'll get to catch my breath and take a drink and maybe suppress this cough a little more successfully. As I ran through those measures, the protective factor survey isn't something that will be required for benchmark reporting next year. There's none of those measures that would look to the protective factor survey, the data source. So we're going to take a quick poll of your programs. Please let us know if you would like to keep the protective factor survey or if you would like to let it go by sending in your comments in the comment box, and please be specific about your site. So we will follow up by email with any site that doesn't respond here, but if you can respond here, then that will save you and us a little bit of email. So if you could say if you'd like to keep the protective factor survey or let it go, and note your site in the comment box, that would be great. And lots of debate out there about the survey, and certainly you can think about it and let us know. We recognize that there are some new challenges associated with these measures that we have not faced before, and we're doing our best to look through and see what is no longer needed and take those things out. As I come through, I have Elsa singing in my head. Monitoring the chat box, but just to ensure that we have plenty of time for a little bit of back and forth. Move on to the next slide. Okay, so just a brief overview of our next steps for each model. Our NFP, local implementing agencies, the National Service Office is working with Efforts to Outcomes and HRSA very closely, changes to the collection forms and the data collection system to accommodate all of HRSA's requirements under these benchmark measures. What we're doing is do our best to stay in the loop with those conversations as they unfold and decisions as they're made, and incorporate that into our plans for reporting. So we're trying to align as closely as we can to what SO is working out, and we'll be collecting through ETO. So question comes through about the supplemental data collection form, and we are anticipating that there won't be a need for the supplemental data collection form in the next fiscal year. That NFP is working very hard to make sure that they are capturing adequately all the data points needed to construct these measures in their existing system. The details of all of that are still very much being worked out, so we're not quite totally there yet in understanding specifically how that will happen, but there's a lot of progress that's been made and a lot of communication, it seems like, happening between HRSA and NSO through the new benchmarks, and make sure the system can accommodate them fully. When changes are made and ready to be released, we will do our best to be really well coordinated with so that you're receiving the same kind of information from us that you're receiving from them. So we're informed of what they're doing and what they're training you on and informing you about. Try to be as smoothly as we can all on the same page through this transition period. So for our HFA local implementing agencies, Healthy Families Online will be the data system that everyone moves to the next year. Right now, Healthy Families Online is also working through adaptations to their forms and the data system. They're going through their back and forth with HRSA to make sure that the way that they're capturing data is adequate, and we are getting updates from them on the changes that they're planning and making as they happen. Again, our data collection and reporting plan to HRSA for Michigan as a state will align as closely as it possibly can to what Healthy Families Online is its system to look at to the benchmarks. And again, just like with NSO, we will be trying to be in very close communication and collaboration with Families Online as they get to the point where they're ready to roll out new forms and train on changes to the data collection system itself. So again, trying to get all on the same page, trying to connect as closely in with that system as we can and pull data out of that system in the way that they're modifying it to work for the set of benchmarks. For our EHS, local implementing agencies, and a new PAT agency that will be joining the Michigan Home Visiting Initiative, we are shifting to a REDCap system away from our paper-based system. So we're developing right now forms that will translate into a REDCap electronic system to capture these data along the required timelines. We'll be scheduling a training with sites that will be using these paper forms and the revised system to kind of go over all of the details of how that will work and to try to provide support for thinking about the timelines and thinking about what data need to be captured from whom and entered where, all of those details, all of those pieces. We're hoping to be able to train in and have something along those lines once we can get the system all built and tested and ready to go. As you can imagine, our timeline is really short, and we're still waiting for approval for our specific data collection and reporting plan to happen. So the time for putting these things together is limited, but we know that you work with us, and we'll work with you to accommodate what HRSA is asking for, and do our best to do good data collection and reporting so that they have the evidence that they need to continue to argue for support for this really absolutely critical work that you're all doing. What do you have that we can answer today? And questions floating through your mind. You're getting acclimated to this kind of new world of measures.
Question, you can feel free to unmute your line and just ask it verbally, or you are welcome to send it through the chat.
One question I have is, as we're looking at how many areas you have to report on, whether or not services were received after the referral was made after a positive screen for some, the case in some of them, and then other situations like the tobacco cessation, the interpersonal violence, where those where they only refer to referrals and not services.
That's a really good question. I'm afraid I can't answer the why about very many of these measures. The process for developing these was very much at the national level. I know that they were very much informed by the home visiting coin, that measures where they're talking about screen referral, they had some sense from the or services. They had some sense from the Queen that for maternal depression, this is something that could retract, it could be reported. It was reasonable to think that there might be improvement in this area. So I know that piece of consideration was put forward. I also know in the dialogue there was pushback on the idea that home visiting programs should be in some ways held responsible for receipt of services, since it's not necessarily in their control whether or not services are received. So my guess is that it's kind of a compromise between those folks thinking, well, if services aren't received, then we wouldn't necessarily expect anything to improve for the family, and those folks that are saying, well, that's true, but at the same time, is it fair to hold home visiting programs accountable? My guess is that it's a compromise, but that I wasn't at those tables to be able to say exactly why that decision was made for each of those measures. Thank you. Encourage you as we move forward toward the next fiscal year to take some time with these measures themselves to get more familiar with them, more comfortable with them. I know as you do that, you'll have questions, as we've had questions about exactly what they mean and why they're set up that way. I think that getting familiar with the measures will help the data collection procedures as they change make more sense. I think it'll be supportive to you and the staff that you're working with and supervising to get comfortable with ideas and kind of what they mean for the way service delivery will unfold. So I'd encourage you to kind of take some time with the slides. Was someone else going to ask a question? Hearing no other questions, thank you very much for your time and participation today. I'm really glad I can't get you sick over the phone, but I apologize for my coughing along the way here today. Again, thanks for your participation, for hanging in there with us through these changes. I know the next couple months we'll probably hit a few bumps in the road, but as I said, after these many years of working together, I'm confident that at the other side of it, we'll be able to get HRSA what they're looking for to achieve the goal that all of us are of being able to sustain and continually improve these services for families. So thank you again for your participation, and have a very nice afternoon.